Hello, and welcome to the third webinar of this three-part TelePET webinar series on teaching endoscopy. Today's webinar focuses on assessment and feedback for learning. I would like to now introduce one of the course co-directors, Dr. Shivakumar Vignesh.
Good morning, everybody. Welcome. On behalf of the World Endoscopy Organization and my co-director, Dr. Catharine Walsh, I welcome you all to our third webinar on our series called TelePET, Program for Endoscopy Trainers. We call this Teaching Endoscopy series of webinars, and the topic for today's webinar is assessment and feedback for learning. So it's my pleasure to work again with Dr. Catharine Walsh, my co-director, and Dr. John Cohen, the World Endoscopy Organization PET Program Director. And we have a guest speaker today, Dr. Rajesh Keswani from Northwestern University Feinberg School of Medicine, who's another passionate endoscopy educator and here to share his expertise. So to recap, the TelePET webinar series had these three topics covered. So far, we have done a framework for enhancing endoscopy training as our first webinar. And then we had a webinar on how to best use simulators to enhance endoscopy training. And today, last but not the least, a very important topic for endoscopy trainers, feedback and assessment in the context of endoscopy training. So the objectives for today's webinar are as follows: to discuss the importance of measuring endoscopy performance during training, to identify best practices for integrating assessment and feedback into endoscopy training, to describe currently available endoscopy competency assessment tools, and to identify opportunities for improvement in assessment and feedback practices. The agenda will be as follows. We'll have two 20-minute talks. The first talk will be by Dr. Catharine Walsh on assessment of endoscopic competence, principles and best practices. And our second lecture will be by Dr. Rajesh Keswani on implementing endoscopy assessment during training, tips and tricks. Following this, we'll have a 20-minute panel discussion between all faculty, Dr. John Cohen, Dr. Walsh, Dr. Keswani, and myself. I'll moderate this session. During this session, you will be able to interact by typing your questions in the Q&A box. And I'll do my best to get all of your questions answered in this 20 minutes. And now I will hand it over to Dr. Catharine Walsh for her lecture. Dr. Walsh, thank you.
Thank you so much for the kind invitation to present today. So as was mentioned, I'm going to outline some best practices and principles of assessment, and then Dr. Keswani will discuss some specific examples regarding endoscopy assessment tools to highlight these principles. So traditionally, there's been tremendous site-to-site variability in the way that endoscopy is trained and how people implement assessment. But over the last decade, there's really been a shift in education, and there's become more of training has become more of a priority, and there's been more of an appreciation that assessment can really help to foster training, both in terms of feedback provision, but also helping to identify gaps in learning. And it's also important to ensure that practicing endoscopists are continuing to perform to the best of their abilities. So broadly speaking, when we think about assessment and why we assess endoscopists, both during practice and in training, assessment serves many functions. One of these is around quality assurance, so making sure that individuals are continuing to perform their jobs and remaining competent. It helps to guide teaching and identify areas for improvement. And finally, it helps to really document learning and enable people to progress through learning. And when we think about assessment of endoscopic skills, we first have to consider how we define competence in performing endoscopy. And broadly speaking, competence can be defined as a minimum level of skill, knowledge, and expertise that's derived through training and experience that's required to perform endoscopy procedures both safely and proficiently. And in thinking of endoscopic skills specifically, we must have a clear understanding of kind of the skill sets that go into performing endoscopy. And traditionally, the requisite skills to perform endoscopy have been categorized into two core skill sets: technical skills and cognitive skills. And an example of a technical skill or a motor skill related to endoscopy would be scope handling or torque steering, whereas an example of a cognitive skill would be knowledge and application of endoscopically derived information. So things like equipment selection or lesion recognition. And while the acquisition of technical and cognitive skills are really fundamental to performing endoscopy, there are additional integrative or non-technical skills that were increasingly recognized are really part of performing endoscopy. And these are higher level competencies that are required by an individual to integrate their cognitive and technical skills to perform the skill safely and effectively. And endoscopic competence should really be thought of as embracing all of these skills, the cognitive, technical, and non-technical. And examples of endoscopic non-technical skills are things such as communication, teamwork, situational awareness, leadership, and judgment. And these are really crucial to effective team working within the endoscopy suite. And there's been a number of studies now to show that training in non-technical skills improves performance and patient outcomes, and that non-technical skills are correlated with patient safety incidents and other markers of competence. So going forward, it's really that non-technical skills are considered an essential part of endoscopy quality assurance. And displayed here is a learning curve, which graphically shows kind of the relationship between learning and effort over time. And with regard to learning endoscopy, learners' performance generally kind of is slow to improve in the beginning, and then they have a quick steep learning curve. And then eventually one gains competence, and then over time and practice, hopefully their skills continue to improve. So I would ask you, in thinking about this learning curve, where do you think you are on this learning curve? And how do you know that? And what are you measuring to know that you're at a particular point on the learning curve? So how do we measure performance? We could look at adverse event rates, although they're quite infrequent often. We could look at other quality metrics such as adenoma detection rate, which is applicable in adults, but not necessarily in pediatrics. So we don't necessarily have a single measure to look at endoscopy performance. If you think of colonoscopy as an example, some basic expectations would be that you expect a complete examination for an appropriate indication. You want them to make sure that they've seen the entire bowel, including the cecum and ileum, and you'd want to be in a facility with an appropriate team, and you'd hope that all the mucosa is seen with pathology identified and necessary therapeutics, and you'd all want this done within a reasonable time frame without complications. And if you could achieve all of these things, that you'd think it would be a high quality endoscopy. But how do you know that? By measuring it. And often one of the things that was traditionally always measured during training was numbers. But we know now that numbers don't tell you the whole story. If you've done 100, 500, 1,000 procedures, what does that mean? We know that people learn skills at very different rates. And that numbers themselves don't tell you a lot about an endoscopist's skill or their attitude, their judgment, their teamwork. So numbers are not a great measure of how competent somebody is with regard to endoscopy. And in reality, individual learning curves look something like this, where everybody learns at very different rates, and their path to competency is very different. So instead of now saying that people have to perform a set number of procedures, most credentialing guidelines now talk about competence thresholds, which are minimum numbers of procedures that are recommended to be performed before you assess competence. And this really points that, yes, you have to have practice and you have to perform a number of procedures, but that's the point at which you can assess whether somebody is ready for independent practice or to move on in a set stage of their career. So this really points to the importance of assessment and using assessment to actually determine whether somebody's ready to progress. And broadly speaking, assessment methods are strategies, techniques, tools, and instruments for collecting information to determine the extent to which learners demonstrate desired learning outcomes. And when we think of endoscopy, kind of the two broad categories of assessments that are generally used are quality metrics as well as skill-based assessment tools. So going back to the learning curve example of colonoscopy, if you look at this learning curve, for example, your technical skills could be kind of here, while your cognitive skills could be a bit lower, and you could be having trouble with your integrative skills. So how can you measure things to make sure that you're picking up on all of these different types of skills? Well, as I mentioned, one thing to look at is quality metrics or key performance indicators. And quality metrics are really surrogates of competence. So these are things that we can measure that indicate your performance in other things that are harder to measure. So for example, if you want to consider colonoscopy again, as a surrogate for technical skills, we could look at something like cecal intubation rate or terminal ileal intubation rate. And I just want to go through, before we discuss quality indicators a bit further, I'm just going to get you to go through an exercise and think about if you were going for an endoscopy and you were presented with 3 endoscopists and their cecal intubation rates were 100, 98, and 92, which endoscopist would you choose to have your procedure with? So people may say A, but I think if they're saying their intubation rate is 100%, they're probably lying. So I would probably go with B. And then if we also look at their pain scores, your choice may change. So you may want to now go with endoscopist C, as they have a better pain, they cause less pain during their procedures. And now if we add in a marker of sedation use, what do you think is the best endoscopist now? So it may be likely C, as they get around most of the time and they have a decent cecal intubation rate. They cause little pain and their examinations are completed in a reasonable time with minimal sedation. And finally, if we add an adenoma detection rate, this may change your opinion again. So again, you may go back to B because they actually have a high adenoma detection rate, so they're able to pick up pathology adequately. So this little demonstration is just meant to show you that it's really a combination of quality metrics that are ideal. In looking at any single quality metric, it probably doesn't give you an adequate holistic picture of how an endoscopist is doing. And we have to look at variable indicators. But how do we know which indicators are best and how to combine them? And that's an area of emerging research. There's one study that was done that looked at a surrogate of measures, and this came out of the United Kingdom. And they looked at a number of measures, but what they found is that a combination of sedation and reaching kind of a minimal level of sedation, patient comfort, and cecal intubation gave you the best composite score that enabled endoscopy units to pick up issues with regard to either endoscopists or the unit as a whole that were amenable to quality improvement. So things like bowel preparation or unit accreditation, so things that could be acted on to improve performance. And in practice, it's important for endoscopists to monitor their quality metrics so they have a clear idea of where they are and they can track their quality metrics over time to identify areas for improvement and help create personalized learning plans. And in this way, they can be deliberate experts and continue to improve over their careers. And one way to do this is through something called audit and feedback. So an audit is where you collect data over a specific period of time, and it allows you to see how you're doing and highlight kind of discrepancies between your current practice and a benchmark or an optimal performance. And this helps guide your practice and identify areas where you can improve. And for audit and feedback to be effective, providers need to be delivered feedback in a timely manner. And the feedback should be personalized, it should be credible and relevant to the endoscopist. And it's also important in setting up an audit and feedback that there needs to be some system in place that if individuals are identified as low performers, that they're provided with an educational plan and necessary kind of education and training to help them attain that minimum quality target. So in this way, quality improvement really should be viewed as supportive rather than punitive. And measuring key performance indicators is not easy as it takes time and requires appropriate IT integration. And a routine and reliable data collection mechanism is really key to this. Some of the electronic health providers are now creating quality dashboards where people can actually see their quality metrics, which really helps to visualize their data and help to really clearly display it to the endoscopist to aid in their quality improvement efforts. And at the endoscopist level, there's plenty of evidence supporting the effectiveness of audit and feedback. There was a recent systematic review and meta-analysis that showed that it can enhance adult-focused quality metrics. And this was particularly true for low performers. And in the United Kingdom, there's been a huge quality improvement effort, and they've actually shown increases in their cecal intubation rates from 76% in 1999 up to 92% in 2011. So now that we've discussed quality metrics in practice, I'm going to discuss a bit around trainees and how we best assess trainees during their training period. So what about quality indicators with regard to trainees? Well, one issue with them is that they lack a lot of granularity. So they don't provide a lot of specific feedback to the trainee. And additionally, the traditional metrics have really focused on the trainer and not the trainee. So we may have to think of some alternative metrics for trainees, which Dr. Keswani will discuss later, but this really has not been done yet. So in thinking of assessment kind of during training, one way to conceptualize this is something called Miller's Pyramid, which looks at kind of what you're trying to assess and how best to assess this. So if you want to assess knowledge, you would use something like a multiple choice test. Whereas if you want to assess how somebody is doing either in the simulated setting or the practice setting, you really want to use more of a direct observation tool. And with endoscopy, we're really looking at kind of how trainees perform within the clinical and simulated setting. And with this, the best way to do this is through performance-based assessments. So these are tools that really provide a means of assessing trainees within the clinical setting through direct observation. So the faculty watches the trainee and then provides them with a rating. And direct observation of procedural skills really is the preferred method. And this really helps to facilitate goal setting, to identify areas of deficit. It helps to really deconstruct the task into the component parts, which helps with the setting goals and providing feedback. It enhances feedback provision and aids in identification of gaps. And it also helps trainers and trainees to develop conscious competence or an awareness of what the procedure entails. And they also are very structured, so they can help to reduce bias. So we know from the literature that assessment drives both teaching and learning, and assessment can serve many different purposes. But broadly speaking, there's kind of three main purposes: diagnostic assessment, formative, and summative. So diagnostic assessment is assessment to plan learning. So if I'm with a trainee and I want to kind of tailor my training towards them, I can use an assessment tool to help plan that training. Whereas formative assessment is low stakes assessment, and it's assessment that's meant to drive learning. So this is assessment that really helps to provide trainees with feedback, individualized feedback, helps them to reflect on their skills and improve their performance. And this is akin to kind of, if we think about a flower blooming, it's the nutrients and the water helping that flower to become a beautiful full bloom. Whereas summative assessment, alternatively, is high stakes assessment or assessment of learning. So this really aims to produce an overall judgment to determine whether somebody's competent or ready for practice, or whether they're ready to advance onto a specific level. And this is not kind of focused on specific tailored feedback, but it's more focused on making sure somebody has reached a specific standard. And this would be akin to something like a driving test, where you take a road test to make sure that you are then safe to drive on the road. So how do we integrate these different types of assessment into endoscopy training? In the first webinar, we talked about a training framework called the Preparation Training Wrap-Up. And you can, if you hadn't seen that webinar, you can link to it on YouTube via this QR code. But basically, we structured the endoscopy training session around things that you can do ahead of the procedure, during the procedure, and after the procedure to help structure the procedure and help provide feedback to the learner. So ahead of the procedure, assessment can be used upfront when you want to get you want to get to know your learner and you want to see at what level they're performing. And this is more of a diagnostic assessment in that you want to see how they are so that you can tailor what activities you're planning for the learner. Up front, it can also help to set learning objectives. So knowing the level of your trainee can ensure that the objectives are relevant to them and that they're achievable or they're within their skill set. And additionally, the content of various assessment tools also help to guide learning objectives because they often break down specific skills into their component parts and can give you an idea as to what you may want to focus on. So things like loop resolution or torque steering. During the procedure, formative assessment can be used to provide a focus for instruction. And then after the procedure, when you sit down with the trainee and debrief with them or provide them with more detailed feedback, the assessment tools can also be used at that point in time to really help guide that feedback discussion. So that's within kind of one endoscopy training session. If we think about an entire fellowship or a program for training endoscopy, we want to think about how we strategically place assessments throughout that training program. And many programs worldwide are moving to what's called a competency-based education model. So this is a model where trainees have to demonstrate that they've met set performance outcomes and that you have to assess trainees to demonstrate that they've actually achieved these by the end of their training. And to do this, you really need what's called a programmatic assessment or a program of assessment. And what this is that you have deliberately arranged assessments throughout training that provide you with different perspectives of the trainee and how they're doing over time. And then those can be reviewed by the training program director or a committee to make sure that the trainees progressing and reaching competence. And assessment, to do this, something that can really facilitate this is an assessment dashboard where people have access to their assessment metrics, and it really shows them how they're doing in specific skills. And if we think even more broadly, kind of over our careers, how we can integrate assessment, if you think about during training, we talked about diagnostic assessment and looking at baseline skill ability, as well as formative assessment and monitoring progress over time. Once somebody's ready for certification, we use a more summative type assessment to make sure that they're ready to practice independently. And then finally, when they're in practice, we can use formative assessment to foster quality improvement. And as well, we can ensure that they're ongoing with their maintenance of competence. And this is more of a summative type of assessment. And just to finish off, I just wanted to touch briefly on simulation-based assessment. So within simulation setting, we can use assessments to make sure that somebody has kind of achieved a level of performance that they're ready to go and try this skill in the clinical setting. We can also use assessment within a simulation-based program in what's called a mastery learning approach. And again, we had covered this in detail in webinar 2. But this really is an approach where you have a baseline assessment and then you have clear objectives or learning goals. And before the trainee moves on to the next stage of learning, they have to demonstrate competence in a specific activity. And it embeds formative assessments throughout the learning activity. So the tasks are arranged kind of in sequential levels of difficulty where they move from one to the next. And to determine whether a trainee moves from one to the next, you have assessments so that if they're doing a basic skill, they demonstrate that they can handle the scope appropriately, and then they may move to the virtual reality simulator where they demonstrate that they can reduce loops or torque steer appropriately, and then they may move on to a skill such as polypectomy, and they demonstrate competence in that. So I hope I provided you with some kind of broad overview of the principles related to assessment. Assessment is really a crucial component of learning and necessary to ensure competence for independent practice. It's also essential to foster feedback and learning during training. And when you're thinking about assessment, you really want to think about integrating quality metrics into practice as an ongoing mechanism to identify deficits and promote quality improvement. And then during training, there's a lot of good assessment tools, which you'll hear about shortly, which can be integrated to provide feedback to the trainees. And you really want to think about assessment kind of in a broader level and how you can integrate assessments across training to foster learning. So I would encourage you all to strive to be deliberate experts in terms of embracing assessment as a means for quality improvement throughout your careers. Thank you.
Thank you very much, Dr. Walsh. Next lecture will be Dr. Keswani on implementing these tools, tips, and tricks. Thank you.
That was a fantastic lecture from Dr. Walsh, as always. So it's always humbling to follow her, but I will do my best to take the principles she's discussed and bring them into a bit of a discussion about how you can utilize them in practice more broadly. So, thinking about endoscopy specifically, we're going to talk about this question of competency again and why we're discussing it. And then I think very importantly for us in training programs, how we can get our trainees to achieve competency, because it's not just enough to measure, it's to get them towards that next step. And so I think this is something that, Catherine touched upon, early on, when she said, we never really can see where we are on a quality metric curve until someone measures it for us, right? Most of us think we're above average, but when you actually measure it in practice, you always find some sort of bell curve, right? And so when we measured adeno detection rates at Northwestern 10 years ago, everyone initially thought they were going to be above average, but obviously there was a 5-fold variation. And we see this a lot, not just with independent endoscopists, but we see it with trainees as well. So it's really a question of how do we get these measurements to occur in trainees? And once we measure them, how do we make sure that everyone is at least at what we would call competency? And this isn't just in colonoscopy. Dr. Walsh showed us a lot of nice slides on colonoscopy competency, because that's what a lot of us do the most. But we've seen this in therapeutic endoscopy procedures as well. A very nice study that out of Europe that basically says that ERCP quality also varies significantly between endoscopists. Your procedure success rate can vary between 60 to 95%. Just like was shown in the prior talk, it's not just about achieving success in reaching the bile duct. It may be about outcome measures of pancreatitis or patient comfort, or how well the patient understands the procedure and what you were doing, whether it was done for an appropriate indication. But regardless of that composite measure you choose, we know that the quality varies widely for all these procedures. So, as someone who's been in practice now for 15 years, you start to wonder, if we all started as trainees, none of us knew how to do endoscopy at all. How do we get to this point where we vary so widely in quality from the lowest performers to the highest performers? Something's occurred during training where we've quite honestly failed as trainers to make it so that people come out of practice not achieving the competency that we require. And a lot of that is touched upon in the prior talk. It's because there's really no such thing as an average trainee. When we look at a lot of these guidelines from a decade plus ago, we talked about volume metrics, as Catherine mentioned. And volume metrics are based on what's called an average trainee, right? So this really nice study out of England using the JAGS database, where they basically showed if we plot the average trainee reaches ceco-intubation at 90% of the time at about 230 colonoscopies. And that's not, it's interesting, but when you look at the individual trainee, some trainees achieved high ceco-intubation rates at 100 colonoscopies, some took 300, some took up to 500. So although it's very interesting to think about the average trainee, it doesn't tell us on an individual level what that trainee needs to achieve competency. We see the same thing for upper endoscopy. We can plot the average trainee, maybe try to figure out how to construct our training program, but some trainees are going to need more help more cases to achieve competency. And we've seen this also in therapeutic endoscopy procedures. This is a study we performed a few years ago using endoscopists, training endoscopists and trainees who are learning ERCP and EUS. And we essentially found that, like you'd expect, we can again plot these very pretty average curves where we say, okay, maybe trainees need about 125 native papilla cases to achieve competency in ERCP. But when you look at the individual trainee, it sort of gets messy. Some people never achieved competency during their training. Some achieved it quickly. So until you measure this competency in practice, you're going to have a problem in trying to remediate and improve training quality. And just to step back from endoscopy, we'll see this in the more cognitive parts of gastroenterology as well. A nice study that was performed showing that same kind of issue occurs in things like reading manometry. Some trainees achieve it quickly. Some trainees take a long time to achieve it. In 15 years in my career, I'm still trying to achieve it. So it does vary widely between the learner. And so until you recognize that, it's very difficult to act upon it. And so I think Catharine showed very clearly, hopefully I've also emphasized that volume doesn't equal competency. But when we ask trainers what they're doing to measure competency in their programs, 85% of them are still using procedure volume as their, one of their surrogate measures. And a minority, less than 30%, were using some sort of structured skills assessment tool and how you measure competency. So we have a real gap between what the data would tell us and how we should measure competency and what we're doing in practice. And so it's programs like this, can't thank the WEO enough for putting this on. It's programs like this that really will get us to that next step. Part of the problem is that we're not actually, as trainers, we're sort of failing our trainees in many cases. When we did a survey of trainees and asked them what's happening during the actual procedure, is someone giving you feedback or how are they doing that? They said that a lot of the times the trainer is not actually watching the trainee or the screen during a colonoscopy procedure. Yes, during first year fellowship, maybe half the time during insertion, the trainer is watching the screen, maybe giving some feedback. But as you get to third year fellowship, where you're really trying to, hone in on those skills and refine them, maybe only 30% of the time the trainer is watching the screen. So we need to fundamentally restructure this idea of how we're training endoscopy. So I think we know so far there's variation in attending competency and quality. This variation likely begins during endoscopic training, which is largely focused on volumes rather than competency assessment. We need ways to measure and improve trainee competency using validated tools. So what kind of tools are we going to utilize in practice, right? So how are we going to assess and improve endoscopic competency in practice? Well, I would argue that there's probably 4 ways we can do this. Largely 3 ways, whereas the 4th way, AI, helps us utilize the first 3. We can utilize quality metrics, as Catharine mentioned, skills assessment tools, and simulation-based learning. And I won't touch on simulation-based learning much because it's already been really, well covered in prior talks, as well as Dr. Walsh's talk this morning. So let's touch again about quality metrics and audit and feedback. What does that mean? Well, we know, from multiple studies that measuring quality and giving feedback to endoscopists is effective, right? So that if I measure how your ADR is and tell you how good it is, you might improve based on that feedback. Ironically, it seems to work often best on high quality performers who may be motivated to improve their skill intrinsically. At Northwestern, we have a data warehouse that runs these reports on demand. And so I can pull up my ADR, how many cases I've done, my insertion time, my serrated polyp detection rate, all these sort of things, and can give me that feedback. And this is a huge motivator for our endoscopists. But what does that mean for the trainees? As Catherine mentioned, traditional metrics may measure the trainer rather than the trainee. And so just giving trainees their ADR doesn't really help. We've tried some other modified ways to measure trainee quality metrics. This is something called an adenoma miss rate that you can do during tandem colonoscopy. And so you can utilize this in your practice now, at least as a teaching mechanism. This is the case where the trainee gets the cecum under attending supervision, and then the trainee does a withdrawal to the splenic flexure, identifies polyps without attending input, and then obviously the polyps are removed in conjunction with the attending. But then I, as the attending, reinsert the scope to the cecum, perform a second inspection of the colon, and remove any missed polyps. So this is essentially like a measure of ADR, but this is called an AMR, adenoma miss rate. And you can see that during training, trainees start to get better and better at finding polyps because their adenoma or polyp miss rate decreases over time. And it seems to plateau around the 400, 450 colonoscopy mark. That seems to be when trainees stop missing so many polyps. And so we could potentially utilize this in training. Trainees always want to calculate their ADR. We could emphasize that, maybe they do 20 colonoscopies. We look at their polyp miss rate and figure out, are they really doing a good job at detecting polyps? And this was touched on, the idea of cognitive and technical skills by Dr. Walsh earlier. But, this is an example of a polyp that a trainee missed during a tandem colonoscopy in this picture or this video. And I would argue this is a cognitive skill that's missing, not a technical skill. The polyp has been displayed on the screen. The trainee doesn't recognize non-polypoid morphology, which means that I don't need to just teach them how to look behind folds. I also need to teach them how to recognize these polyps. But it's not just about these quality metrics because it's limited. We need to also measure skill. And why are quality metrics themselves limited? Well, even if you look at sort of an analogous thing, which is surgeons, we've tried this. A website in the US called ProPublica tries to give patients some information on how to select a surgeon for a cholecystectomy. And so they'll pick these outcome metrics like, complication rates. But if you look at things that are low volume, like a gallbladder removal, the surgeons tend to be both below average and above average because the confidence intervals span widely from low adjusted complication rates to high adjusted complication rates. It's very hard to measure quality metrics in procedures where there's lower volumes. And for some of the things we do in endoscopy, like ERCP, the volumes just aren't going to be high enough during training to measure outcomes for trainees by volumes. For example, for ERCP, a trainee may get maybe 100 native papilla ERCPs during their training. And if I say that if their cannulation success rate is 83%, that may be true, but their confidence interval varies between 76 and 91% during that training period. So are they competent or are they, far below competency? It's just very difficult to tell. So that's why a lot of us have moved towards procedure skill, because it correlates with outcomes, but it also gives you opportunity for feedback. We've shown in prior work that you can measure colonoscopy skill in just 5 colonoscopies, which correlates very clearly with adenoma detection rate in independent endoscopists. So skill can let you quickly measure the quality of the endoscopist and also provides opportunity for remediation. And what do I mean by that? I can measure the skill of the colonoscopist here, where I'm actually figuring out, are they reducing loops? Are they pulling back the scope? And give this back to the trainee. In a study we did just a few years ago with US trainees, we were able to give them the skills feedback on how well they're doing on some of these core colonoscopy skills. But unfortunately, despite utilizing these tools, and this was the ACES tool, which has been endorsed by the ASGE, we did found that trainees did not actually improve in their colonoscopy skill. And I think the reason that is because we can't just give people feedback on how they're doing. We need to actually give them an opportunity in how to improve, whether that's through videos or hands-on training. So I'm going to close up in the next couple of minutes showing you that, we can give these skills feedback. We can give people some opportunity to understand how they perform, give them opportunity to learn on what they should be doing better. This is how we've done this at Northwestern. Tell people how they perform, but also tell them what they need to do to get better. You don't look behind the folds well enough, or you don't remove this polyp well enough. Here's what you need to do better. And this would be an example of showing people you need to do a better job of looking behind folds. That's why your ADR is lower. Not only tell people their outcomes, but what they can do to improve. We can do this for polypectomy as well, to allow people to improve their quality. Tell them how they're not performing adequately and what they need to do. We've done this for ERCP as well, measuring the technical skill in ERCP and showing people what they can do to improve their skill. You're not performing as well in cannulation. Here's why. You're not aligning and maintaining the position well. Utilizing these tools, and this is utilizing something called the BSAT tool, utilizing these tools can help us achieve competency. We've also talked about personalized feedback, where we can actually tell trainees specifically, showing them what they need to do to improve their skill, videotape their procedures, and help them improve their quality of ERCP. These are all ways we can try to get our trainees to achieve competency, utilizing validated assessment tools and conscientious trainers. I'm not going to touch on simulation-based learning because Dr. Walsh did such a good job on that. I'll close on the idea that AI is going to help us do all of this much better. AI can measure colonoscopy quality, endoscopy quality more broadly. So I see a future world where trainees upload their videos of an ERCP, a colonoscopy, an EGD, and then an AI tool can tell them, did they get to the cecum in a safe manner, what their withdrawal time was, how they remove the polyps, what the skill they remove the polyps was. All of this can be done by AI if we put the investment into it. And so this is, I think, the future of making all of these tools that we talked about readily accessible to all of us. So in summary, I would say that the future state of training really needs to be on trainees performing procedures, and then at a short interval, at 1 to 2 months, getting some sort of automated or semi-automated assessment of performance, so that the trainees can understand what they need to work on it, and then get, after 1 to 2 months of this direct actionable feedback, another assessment of competency, so that they can continue to work iteratively towards independent practice. And once again, I want to thank the WEO for the opportunity today, and I'm looking forward to questions.
Thank you, Dr. Keswani. That was a very nice follow-up discussion to Dr. Walsh's talk. And both of you gave us tremendous amount of information to think about. I want to remind, all our panelists have our videos on, and want to request our audience to please post any questions in the Q&A box. I will be the one to, ask the questions and get them answered. So please post the questions. Just to get this started off, I can think of a lot of questions. But one of the things, I think the take-home message is there's really no average trainee, and as trainers, we really need to know, how to assess cognitive, non-technical skills, technical skills, and the tools, direct observational tools, and how to really utilize them. So one of the questions I have for the panel, obviously there's a learning curve for trainers too in using these tools, and I would imagine there's some variability in how as trainers we rate trainees. The broad question is, how do we address that variability? Do these tools sufficiently address that variability? And take it another step further, we have these simulators, which we're slowly integrating into our training, and then we have real, patient-based training. How about the variability in those assessments and how to integrate them? So, and any of you can get this started, but those are the questions I had. So Dr.
Yeah, so I
Walsh.
think first with regard to raters, we know that people interpret things slightly differently. A lot of the studies that have been done use kind of minimal rater training, which is more akin to how you would use them kind of in the training environment, that most faculty within a department won't have extensive training on an assessment tool. And they have shown to have good reliability and validity, which is promising. We just did a study looking at kind of how raters decide whether they're going to entrust somebody as competent in performing endoscopy. And it came out of that study that there are many factors beyond even how the trainee is doing that the raters consider in making these decisions. So things external to the trainee, for example, if it's a high-risk patient, if they're kind of aware of medical legal implications, like how time crunched they are, the age of the patient, their own personal skills as a trainer, if they're maybe more early in their faculty position and are not as comfortable with their own skills. These are all things that raters take into account in assigning a rater. And I think the big thing is trying to get raters to give as detailed open-ended feedback or written feedback as possible, because that helps to qualify kind of some of their judgments and what they're basing those judgments on.
If I go ahead, John.
I was going to say, in a practical sense, you're in a program, and time's a factor. First of all, you need to create and allocate time for assessment, whether in all the ways we've talked about this morning. It just is essential that you allocate. When you're doing a hands-on workshop, you have to do that initial assessment to see where you start with. You have to then do it as you're going along, and then when you're finished to see what where one is. We did that back in the hemostasis trials of simulators. So you need to create time. I also feel like many programs, when we do these PET programs in different countries, we ask, have you ever got together with all the faculty that teach and standardize the way you teach in general? Well, this is an important part of it, how you assess. So I think that it's important that the trainees get the same kind of messages. Sure, there'll be individual variation, but that takes away some of the bias of, oh, I don't want to give them bad results and one thing. And lastly, it creates a culture of self-assessment and improvement. And this whole process, I think, pays off, because when you go out into practice, if you always feel that you're trying to improve yourself, just like your mentors are, I think that'll continue and people will continue to improve. So I do think that if the trainees don't get engaged in the process and ask, please give me the feedback, please assess me, it's seen as a imposition as opposed to a really nice way for the student-teacher interaction to go forward. It actually is a structure. So I think it really is important to standardize at the beginning and to create that culture.
Thank you, John. And yeah, I mean, that's what I was trying to get at. I think all the trainers really need, I guess, more in-depth education on all the tools and, probably more frequent discussions. Dr. Keswani, did you have any comments on that?
I mean, I guess the two comments is, one, there's still a gap between the tools which have been utilized most in research and less in practice. And so reducing that gap, we know that there's some variability, but not this exorbitant variability in research studies. But how it extends into practice when, I might want to rate Dr. Cohen's endoscopy skills, but I'll be like, he's got great hair, and that's how I sort of give my global assessment. I think you don't know how it's going to translate into practice, which is why I think these really, really structured and specific skills tools versus these global assessment tools reduces that variability, right? Does the fellow put the polyp at 6 o'clock during polypectomy? There's less variability there than is polypectomy competent, right? I mean, the more granular you get, the less variability there is, but then it makes it harder to implement into practice because it's a feasibility issue. So, I think bright minds like Catherine have to figure out how to sort of bridge that gap.
You should be looking at the hands and the screen, not at the hair. But let me ask you, just when you we talked about variability of the raters, but when you take a trainee, and you look at their performance using one of the assessment tools, does the variance from procedure to procedure decrease over time as with skill? I mean, do we know how many in real terms, how many assessments of performance of skill at a time period you need to do? Is it 5 cases? Is it 2 or 3 cases before, because there's a big wide variance. You may have a good case or a bad case. So what do you do there?
Yeah, so I think Dr. Keswani, you had spoken about the one study where you looked at the one assessment tool, and it showed that around 5 assessments was able to get a pretty stable view of a trainee. In looking at assessments broadly, it's usually kind of between 5 and 10 assessments will give you a fairly stable view. I would like to point out in terms of the assessments and using them in practice, I think in North America, we don't have a robust kind of assessment system that's used across programs. I think one model that we can look to is the United Kingdom. They certainly have assessments embedded within their training programs nationally, and they have shown that it's feasible to do this, and it provides very robust data for trainees, and it's an extremely strong system of training where they use these assessments regularly throughout training, and then to show that somebody's competent at the end of training.
Thank you. Yeah, you're absolutely right. There's no standardized way of frequency of assessment, but some programs have implemented it. But sometimes there's variation in the frequency based on time, availability, different sites, and so on. In terms of assessment, we're in an age where simulators are used in most programs, but they're not really standardized how they're used. And I think even less standardized is assessment when simulator-based training is used. How do we best integrate, the assessment, is there a summative assessment after simulator-based training? How can that be integrated with endoscopy training in general?
I want to comment on the simulators have this great ability for deconstruction, and you can also put it all together. You can do different things with simulators, but the key is to be deliberate in your use of the simulators. What is my goal today with this session? Are we going to focus on something that the procedural assessment brought out as something we need to work on? And as Raj was talking about, then you go back and you work on something particularly, and then you can assess it and use feedback there on a particular skill. I think that's more useful on a simulator than a global assessment, except the non-technical skills that Catherine was discussing, because to comment and talk about how you're doing with the assistants and communicating in a room, that's a very, very useful area in a simulated session, to put it together and to see how you're organizing things. It's controlled. Just one other comment I wanted to make. I thought Raj's comment about the tandem colonoscopy was really, really interesting, and something practically that people could do in practice, because it actually does something we're supposed to do with all our training, is to make sure we benefit patients too. And you definitely benefit the patient by a second look. So it gets at the problem of how many procedures did you do independently, and how are we going to assess you if you're really cheating to help the fellow, not because the patient is sitting there and you don't want anything bad to happen to the patient. So those kinds of creative ways of doing that was very interesting, and I think something that people in practice can maybe incorporate.
Yeah, John, I really echo your sentiment. That really caught my attention, because it's a highly practical suggestion. So I do think that there was a vote for implementing it. I think that would definitely have my vote. I again want to remind our audience, please don't hesitate to post any question in the Q&A box. We're happy to get them answered. If others don't have a question.
One quick comment to just make sure I follow up on I'm sure that this has been talked about before, but this idea of combining the simulation with the mastery learning is really the sort of the concept there, right? Which is, and I think John talked a little bit about deconstructing the steps. The idea is with mastery learning, you have to achieve competency at each of those individual steps when you're using a simulator. So if you're using a simulator for ERCP, just to make it something a little more complicated, if you're not, gently manipulating the papilla, that's where you fail on that checklist, and you have to keep working on that over and over again. So it's the same concept as deconstructing everything down into individual skills, but you need to achieve mastery on that skill. You don't just pass because you've done 50 simulators. You just do it over and over again. Luckily, there's unlimited number of computer simulations versus there's a limited number of patients. So I think achieving competency through the simulator is pretty well borne out through the literature, and it's coming more and more through work in endoscopy as well.
Thanks for that comment. Yeah, absolutely. I think simulators, while they're getting popular, I definitely think can be utilized better, to really implement mastery learning and, systematically used. Thank you. We do have a question from the audience. It's Dr. Trung Tran, who I know through the WEO. And his question is, do you guys think, can artificial intelligence decrease the importance of trainers in GI endoscopy? And if I might just add to that question, artificial intelligence obviously is really, growing rapidly in its role, most in polyp detection. But, maybe each of you can comment on what's the current status and what do we have in the future in terms of using AI for assessment?
I just want to make quickly. Yes. I think that AI is great. It's very intriguing, and its role in training hasn't really been fully explored. But can AI improve HI, human intelligence? I think it's going to be critical as a non-autonomous system. It's going to rely on the operator to show this to everywhere. And it's also going to be, show all the sites for the AI to work. I think it's been critical to us to interpret what AI brings to our attention. So I think it's going to be an interesting tool, but to not rely on it. So I think it's going to need to really be studied. I'm interested whether Catherine thinks, is there any research that's being intended for this topic?
Yeah, so I think two things to consider is how it's being used in the clinical setting during a procedure, and then, as was pointed out earlier in Dr. Keswani's talk, is using it to debrief after a procedure. So I think, as you rightly pointed out, during a procedure, AI can't see what you're not showing it. So you still do need good technique to actually visualize the lumen. And I think of it kind of akin to simulators, where we've done studies to show that giving trainees metrics from the simulator, so for example, how good their visualization is or their time in readout, as compared to having an instructor there providing them with feedback, they're not equivalent. That having an instructor there providing feedback is much more beneficial to the learner, and they have much greater skills acquisition. I think where it potentially can be very useful is, as was displayed, as a tool to debrief after the procedure, where you can use it to guide kind of a video review of a procedure.
Great, thanks. One of the questions I had, and I think we might have even talked about it prior courses, sometimes it's hard to really capture what you observed in the post procedure feedback session in terms of the trainees' scope handling, or torque steering or other maneuvers. In sports, they use videos of trainees and to really make that point. And I know that it really is very impactful. So what's the feasibility of doing that, getting permission and so on, at least every, 20 procedures, something in the endoscopy training setting? Any thoughts on that?
I'll make one quick comment on it, because Sachinwani and Tanya Kaltenbach led a study that I helped with that was really fun to do for somebody, but not necessarily for the trainers, which was they recorded a bunch of, pyelopectomy videos for trainees throughout the 3 years of their fellowship. And then the trainers essentially watch the videos and give directed feedback on that video using a modified DOPPES tool, essentially. And I think this is really helpful to give, and Catherine can talk more about this idea of not giving feedback during the procedure when it can be overwhelming for the trainee, but giving it to them in an asynchronous time period where they can sit there, review the feedback, watch the video again, understand why that feedback's being delivered. And it did help, the trainees, and it should come out in publication soon. It does help the trainees achieve competency, but it's a lot of work, right? All of these are a lot of work, and that's one skill out of an entire endoscopy field. So, how do you do that in practice is what I'm still struggling with. We have done that study with ERCP that I showed you, where we videotape the ERCP and actually telestrate, show them where they should be cannulating, where their sphincterotomy should extend to, all these sort of things. And that was kind of fun for me once to do the study, but can I do it over and over again for the 100+ trainees in the US? That's where, again, that integration of AI comes into this. So I think it's the right idea. AI will make it potentially feasible, but I'm curious what Catherine and Jonathan think.
Well, I think the video is running the hard. If you have a whole video, to edit it down takes a lot of time. And it would be interesting to develop technology that would allow us to very rapidly sort of tag critical points of a procedure and then go back quickly to that. And I think some people have been working on that, because I do think it's a very effective tool outside of medicine to go back. And when we do the PET programs in person, those are some of the most effective times when we watch. Now, the videos can't just be the screen. Remember, they have to be the hands to see what goes on. So I think that, but it's a very effective tool. And, in terms of some of the courses that we offer in GI and in GI endoscopy, I think an annotated video, edited video, where you actually comment on, look at this sort of difficult thing, not this sort of surprise, wonderful key move, but how do I struggle and how do I get through a struggle to get a difficult cannulation? It may be tedious, but that's not often what's shown. So I think that we should refocus some of what we capture in our video and what we teach with. And I think that we can do more with video. That's not even with, I don't know if AI can help us with that, but I think we should, that's a separate area.
Great, thanks. I'd love to get others' comments, but if I may ask a question that was just posted from Dr. D. Meneses regarding the non-technical skill training. Do you think the problem-based learning approach or peer instruction learning are valid methods for improving the trainees' theoretical knowledge? So I guess these are other the supplementary methods for cognitive skills training, and how do they tie in with endoscopy training? I guess that's kind of the nature of the question. Anybody want to take that? Catherine, can I?
That's definitely a Catherine question. I mean, so screaming your name, Catherine.
So problem-based learning is where you present people with a case and then they work around that case. I think certainly that could help to teach around non-technical skills. I think one of the best methods is through team-based simulations, because you could then actually get kind of an endoscopy nurse or technician or other members of the team working together to work through these issues. I think also with, you talk about peer learning, I think one strategy that has been used is 360 evaluations. So not only having the trainer assess the trainee, but getting perspectives from the nurse or the anesthetist, if there is one, to help them provide feedback on other broader aspects of endoscopy. So I think there are definitely other strategies that you can use to teach around non-technical skills.
Thank you. Thank you. I think we're approaching our webinar end time. Any comments any of you have as we wrap up? I think this was a very, very informative session, and I definitely feel inspired to use these tools better, both in the simulation setting and in the real training setting. So all of you, each of you, any closing comments?
Yeah, I would make a quick comment, just that it can be overwhelming. So maybe focus on one thing that you think is most relevant for your training program. Get a validated tool. There's so many of them out there that I couldn't make the slide to put them together. Figure what you want to work on, get a validated tool, and start that process. And that sort of dives you in. Trying to do too much at one time is going to be overwhelming.
John?
Yeah, no, I would agree. And that way, if you have a consistent tool that's used across trainees, then both the trainee and the trainers become familiar with it. And I think just as practicing endoscopists to embrace a culture of training and quality and use quality metrics in your practice. And that helps to model for trainees kind of this idea of continuous learning and improvement over their careers as well.
Thank
I ditto the culture aspect. I think those of you who are attending who love training, this will make you love it more. It really connects the bond between trainer and trainee. You need to create and work in the time for these things. It's important. It's also good for the patients too, as we can see. We've seen. And lastly, thanks so much to Vignesh for organizing this, and for all of you for attending. I just leave us wanting to hear more, and we're going to do more programs, and any feedback we can get on specific questions after the fact, we'd love to hear from you, so we can continue these both tele programs and also in-person programs for this very important area. So thanks so much for joining us today.
Yeah, thank you, everybody. Yeah, those are great comments. Yeah, we have to remind ourselves it also benefits the patient. So I think that's very important. So I just want to remind everybody the importance of your feedback. So this is a QR code to a feedback survey. Please take a couple of minutes to complete that. This will really help us improve future webinars. There's also a link to handout, or you'll get an email with the course material and the handout. Thanks again for attending. I also want to share, you can share with your colleagues that these webinars, this one and the prior, are available on YouTube. You can watch at your leisure, and you can continue to learn from them. Thanks again, everybody, for attending. I want to share. So these are the webinars. This is the last one, and upcoming courses, Endo 2024, Seoul, South Korea. That sounds good. Hopefully it will be mostly in person. And thanks to all the World Endoscopy Organization staff who have made these webinars possible. It was a great opportunity, and hope we'll keep this program alive and ongoing in the future. All right, everybody. Thank you again for participating.
Thank you.
Thank you.
Thank you.
Thank you.